I'll Hi, everyone. This is Team 4 section of the Ramifications assignment. Our section was how does one distinguish between the contribution of practices and practitioners? Our first set of takeaway points is about how sometimes as clinician we forget that some therapies work better for some clients just because of innate abilities. So we need to be providing some additional attention to those clients that might need some extra supports in order for a certain therapy method to work. So that's kind of where the one section of the evidence-based practice trifecta comes in, that we do have to use our clinical expertise as well in knowing what's best for our clients. On the same hand, that brings me to point 2 here, that oftentimes we know our clients so well that we can't find to identify them in research studies. So we kind of overlook research findings that aren't 100% tailored to our client, but we need to take a step back and realize that, our clients are specific people that we can find treatments for, and we can find treatments for them. Specifically, it says in here that sometimes practitioners feel that if they know their client personally, they're less likely to use evidence-based practice and just go with their gut because of not being able to identify their patient within the population. So our jobs is to be able to take what our clients present with and be able to find those qualities in the populations of research studies so that we can use the best practice for our clients.
Okay, and so for some more takeaway points from our section of the article, the authors talked about when we are either conducting research or treating clients, we need to remember SLPs need to keep in mind some ethical concerns. So like we talked about in Dr. Sevich's class, having groups where we're not providing treatment, efficacy data, randomization of groups, things like that. We have to keep all of those elements in mind, but also remember that we may have to implement some practices before they can be completely validated. So I kind of tied this back to my placement now. We're using a coaching model for in the early intervention that I'm in. And I was doing some research, and researchers first started talking about the coaching model in the 70s. And so SLPs were using this model since the 70s, and clearly they were using it before it could be fully validated. So I just, that's how I tied to what I'm. And for the next takeaway point, the authors mentioned that ASHA and the special interest divisions understand that providing articles on evidence-based practice is not enough for working SLPs. So they've also provided multiple resources. The article talked about multimedia instructional modules to demonstrate specific application of evidence-based practices. And I pulled an example from the article of a post in the ASHA Leader about the marriage of research and clinical services. So this point really just draws on the point that ASHA is trying to provide working SLPs with more than just research articles. They're trying to provide us with resources for how to implement evidence-based practices.
So for the action items of kind of focusing on what we as clinicians need to do related to the section that we kind of are talking about, there's kind of 2 main issues that are happening with evidence-based practice. One is that for treatment models that are kind of tested and then that don't work, there's not studies that go out saying that basically don't use this treatment model. And then the second is that sometimes research gets put out and then it obviously gets dated, but some people are still referencing it. So for the what to do regarding those issues, getting the ineffective approaches out of the system will kind of open up more opportunities for us to increase treatment approaches that do work. So we need to replace existing therapeutic approaches with newer ones, but also consider that what you're using may not be the best or most valid new research out there. So these old and effective therapy approaches are staying alive through clinicians that are consulting old texts or who might be consulting, old supervisors or acquaintances. So instead, really relying on the most recent peer-reviewed literature is something that we need to start doing more often. And then also, I kind of just thought, some people who are kind of stuck in their ways or that really rely on old textbooks or information from colleagues, maybe due to financial reasons or what have you, maybe just not stopping there and kind of just double checking that information. So if you have a treatment approach that's a little bit older, maybe just go back through ASHA and see if anything more up to date has been produced. You don't necessarily have to change your model completely. And then for the second action item, just continuing to be sensitive to the idea that most evidence available applies to populations rather than individuals. So kind of what Chloe touched on earlier, don't just match an article to your specific person. Really match your article to the population, but then further dive in and extend questions to what are my client's specific characteristics, what's the specific intervention setting that I'm in, whether it be a clinic, a school, acute care, whatever it may be. And then are there any other external factors that are affecting your service delivery, maybe cultural considerations or maybe a co-occurring diagnosis, something that might affect the treatment that you're going to apply. And then I feel like we can all benefit from increased training on how to do this. How do we search for evidence-based practices versus just, trying to apply it straight to a person? How do we really dive into finding treatment for a specific person? I think that that's something that we need more help doing, whether it be through courses like this or in our actual clinical practices through the help with supervisors.
So then piggybacking off of some of the action items that Abby just addressed, another action that we can take is communicating and collaborating more consistently with different locations, whether it be between schools, hospitals, clinics, or other settings that are providing similar therapy approaches to better be able to validate or invalidate some of the treatment approaches that are being implemented. So compared to medicine, there are a lot less academic programs or research-based centers that are producing these peer-reviewed literatures on different approaches. So getting better at communicating the efficacy of treatment approaches across multiple settings would help researchers and therapists better understand whether these approaches are working and ways that we can better the practice kind of actively within the practice that we're implementing. So in order to generate appropriate statistical evidence for these treatment outcomes, there needs to be a large number of client participation. So collaboration between sites would help to increase these numbers and start to get some more peer-reviewed literature out that has better statistical evidence.
So we've heard some really good takeaway points, and you have some ideas what to do for your action items, but there are some questions that we can still discuss. For the first one, in your personal clinical experience, Where have you seen gaps between the knowledge of treatment approaches, so the therapies, and the practical application, as in the therapists? One of the neat quotes in this article was, "Life cannot be reduced to the manual, so therapy should be a blend of art and science." So like in reference to the third action item, like providing same therapy approaches across multiple locations. Just think about a therapy approach that we've learned about thoroughly in school, and did you see it executed to the fullest extent of the research, or did the therapist that was using the approach adjust how the technique was done to better fit the individual client's needs? And then for the second question, based on facilities you have worked in, how would individuals best contribute to the conversation of treatment efficacies? For example, I was at Concordia of the South Hills, which is an adult skilled rehab facility, and the PTs, OTs, and speech all shared a therapy gym. So everyone was constantly bouncing ideas off of each other and having an ongoing dialogue about whether a treatment was working or not. But not every type of facility has that opportunity for ongoing communication and being in the room with each other all the time. So what might help? Would like a monthly meeting be useful? Would, if meetings are too much of a hindrance, would an ongoing email blast help, or something like a longer 3-day seminar like once a year? What would help you as a therapist communicate with other therapists about whether treatments are working? And then third question to consider, how might you facilitate the dialogue between, let's say, an experienced SLP, maybe 25 plus years, and then you as a new graduate, about evidence-based practice? Because we all know what evidence-based practice is. We've been learning about it in school, but it was formally introduced in 1992, so it's 26 years ago. There are therapists that have been working for over 25 years, and they probably aren't as familiar with evidence-based practice. And if you were to come to them and suggest this whole new system, that might be something that they might not be as open to. How might you facilitate the dialogue about using evidence-based practice?
All right, so that would be the end of our presentation. Hope everybody is surviving their placements.